Hi, everyone. My name is Lori Bravi, and I am an OT specializing in lymphedema and the neurological population at Shirley Ryan Ability Lab in Chicago. I have been using the InBody 770 as part of my practice for just over 2 years now and wanted to take some time to share the benefits of it from a clinical perspective for therapy. So as I share my screen here, I have a handful of slides. We're going to go through what we know as therapists from a therapy perspective in lymphedema first, and then talk about measurement, traditional measurement using bioimpedance analysis, and then two case studies to help further explain the benefits of using bioimpedance in the therapy setting. So here we have different reasons from an evidence-based perspective why we want to measure or quantify lymphedema. Different amounts of lymphedema measurement will help us with staging. Lymphedema, are they stage 0? Are they healthy? Are they stage 1? As we know, 0 and 1 are reversible, so those are really critical stages to catch patients in for lymphedema, so we can implement treatment as soon as possible. So the staging affects the treatment protocol. Are we doing an early intervention protocol? Are we doing a reduction protocol? Maintenance, what does that look like? We also quantify lymphedema for compliance reasons to give the patient feedback, to let them know what progress they've made or what progress they haven't made if there's someone who has a difficult time following through with home programs. Outcome measures, obviously, we want to make sure that we're using evidence-based outcome measures as part of our justification for therapy and our treatment. Reimbursement purposes, of course, with insurance to justify how many sessions we need for patients, or return surveillance or maintenance programs, and then ongoing surveillance. So these are all reasons why we want to make sure we have a reliable and sensitive system for quantifying lymphedema. So what are we actually measuring? The traditional approach is to use tape measurements or volume measurements. And so a lot of times what that yields is information on the total volume, especially with tape measurement, of the whole limb. So if we look at the center picture here, clearly this is depicting one extremity with lymphedema versus one unaffected extremity. If we measure using a tape measure, we'll obviously get a larger volume of this arm, but it really won't tell us, is it true lymphedema? Is it adipose tissue? Is it muscle mass? This is a really good reason for looking for other options for measuring or quantifying lymphedema other than just tape measure. A newer technology that we're all familiar with since we're here today is bioimpedance analysis. And as we know, InBody has several different options that clinics use. Our clinic specifically uses the InBody 770. So this machine is really great for multi-frequency bioelectrical impedance analysis. And this machine will give us information outside of just total limb volume, which is what we would get with the tape measure. And so we have the added benefit of having information on the fluid volume for the limb, so extracellular water separated out from intracellular water. And as we know, lymphedema, when it accumulates in the extracellular space. And so those ratios are really the focus of the biometric data that we get from the reports through using the 770. We also take into consideration the intracellular water numbers along with the dry lean mass and the body fat mass, because we could be accumulating more intracellular water for these different reasons. If we're doing a lot of strengthening with the patient, we might have muscle bulk that we're considering that could be holding on to more intracellular water that could potentially artificially affect the extracellular water ratio. So we take all of this into consideration with each case. And it's really unique to the InBody products to have all of these different biometrics as a clinician when you're trying to assess what's really going on with the patient, instead of just a a number that's calculated for you without having access to the true data behind each case within each limb. This is really critical to our practice. We have a little checklist here. This is a checklist that I used for myself when I was deciding which technology the Shirley Ryan Ability Lab should invest in. And we did research both of these products for a minimum of 6 months, actually. And there was, in the end, we realized that having access to all of the biometrics I just described, including, not the segmental values for the extracellular water over total body water ratio, or the impedance ratios, or the phase angles. These are all types of data that we have access to because of the technology with the InBody versus the competitor, which just gives you a single value and puts the patient into a range of healthy or at risk for lymphedema. So 2 cases we'll talk about. The first case was a woman who I worked with for several years. She has a history of breast cancer that was diagnosed in 2008. I have a summary here of her medical care combined with her therapy history. She started at a different outside clinic initially. She was diagnosed in 2008. She didn't have symptoms until 2010, initial symptoms for her lymphedema. She was treated at an outside hospital with daily lymphatic massage, over-the-counter compression, so circular knit compression, and was educated to just wear that with travel only, not with any workout activities or cardio activities. I should point out that this patient is someone who's very physically fit. So it was important to her to get feedback about how her biometrics are changing as a result of treatment, but also working out. So you could see that InBody data would be very useful for this type of patient. I began my treatment with her in 2018, so 10 years after her initial diagnosis. She didn't have any problems for a good 8 years with her lymphedema until she had these 2 minor incidents within 1 month time period. They were very small when I saw her in clinic for the evaluation. The small burn that she did have on her hand was fully healed. And the other example was she could recall one incident of pitching her hand while she was working out between 2 weights. So they, might seem like innocent incidences, if you will, regarding a lymphedema exacerbation. But both of these, especially the burn, both of these encounters really created an environment for increased inflammation. And so with that, we know when you have a reduced lymphatic transport capacity, that will put you at risk for your body to have difficulty managing the fluid associated with any inflammation. So when I met with her at her initial evaluation, this was in July of 2018. At that point, we did not have the InBody, and so we only had access to tape measurements, which was the standard of care at that point for our clinic. And so if you look at the summary here, we have her affected, versus her unaffected side. And there was an 8.2% difference initially. She did decline bandaging because a lot of this fluid was maintained in her hand and her forearm, and she didn't want to compromise her workouts. So, after a few weeks, it was about a month of not seeing a significant difference, the patient was finally convinced to have her arm bandaged. I think we bandaged a few times, maybe 3 times. And then we did see this reduction using a tape measurement, volumes back down to a comparative volume almost identical to the unaffected arm. At this point, she was discharged from therapy with a flat neck garment, which was an improvement for containment purposes, as opposed to the over-the-counter garment that she had from her previous clinic 8 years prior. And I did recommend compression class 1 because she's a very tiny person. Her wrist circumference was like 14 centimeters. She was just really tiny overall, like 5-foot frame. And so with that, we came up with the solution to switch to flat knit, but keep it at compression class 1. So fast forward a year, the patient did return in November the following year with increased volume again. She had gone to Europe and had an exacerbation as a result of the air travel. And so she did not wear her sleeve for this, unfortunately, for the air travel. And she felt like, she had managed her lymphedema for a year and a half, and she was going to discharge using the sleeve. She had this exacerbation, returned to me. We measured using tape measure. Again, you can see the difference. We have almost a 15% increase in volume. She agreed to treatment. We did wrapping. She came back down to almost identical lymph values using tape measure again. This time we discharged her with a flat neck garment, but compression class 2 to help with containment properties. And so she did wear the garment regularly at this point during daytime hours. In 2020, she pursued the lymphovenous anastomosis and lymph node transfer microsurgical procedures in Chicago here, and she returned for treatment after that. And I have a summary of her limb volumes in addition to some biometric data from the InBody. It was at this point during her return to the clinic that we had acquired the InBody at Shirley Ryan Ability Lab. And so we were able to use this technology to further extrapolate what was going on in her left upper extremity and her affected limb. And so what we saw was very interesting, and that's why I'm choosing her case to highlight, because we do see these kinds of cases all the time now that we have the InBody. But this is really a great case to try to highlight the differences here, because if you look, her limb volume using tape measurement looks terrific. So her unaffected and affected arms are essentially the same. However, when we did the InBody, we were able to detect an increase in the extracellular water in her affected arm compared to her unaffected arm. There's quite a significant difference there. We did wrap as a result because the cutoff value for 0.385 would suggest that the patient is quite possibly in the stage 1 zone, not even stage 0 at that point. And so she was agreeable to wrapping, which we did. We repeated measurements again in January of 2021, and we had somewhat of a decrease. We kept doing treatment again, and we had finally came down to 0.379 for the extracellular over total body water measurement for her left upper extremity. And so that gave us confidence to discharge again using the flat neck garment on a daily basis. But we had the benefit of using the InBody to reinforce the wrapping that we wanted to do with her. This is just another summary here of how we looked at the InBody data versus the tape measurement circumference. So we have, if you look at the bioimpedance column here, we have the different stages based on her extracellular water over total body water ratios. So here we have stage 1, whereas if you might look at the tape measurement, it might suggest that she was not as severe as stage 1. And then also we started using, this is the other piece of data I want to emphasize here. The extracellular water over total body water is just one piece of data that we've learned to use. At first, keep in mind, this case was someone who I started following as one of the initial cases once we got the technology. And so it's been a learning experience. Monica's been very helpful as my contact on the US side of things for clinical questions and care, try to help tease some of this out. But we used to put a lot more emphasis just on the ratio for the limb instead of the extracellular water over total body water ratio. But then we were seeing some differences with impedance ratios too. So if we look at the two different ratios, we'll see that even though if we look here at discharge, we were in a normal range for the extracellular water over total body water ratio. If we look here for the impedance ratio, we still were coming out a little bit on the high end. So 1.12 would still put the patient as a stage 1 that was confirmed. And this is really important because even though the two ratios might seem like there's a discrepancy there, we have to really take a step back and use this data to provide the most conservative recommendations for the patient. And because this is an evolving technology, we're very careful to explain to the patient and within our own clinical conversations when we're deciding treatment, that we don't have many years of data on these patients yet. And so we have to look at both ratios. So there isn't just a very clear treatment protocol based on the extracellular water ratio compared to the impedance ratio. You might have a discrepancy there. But if you have been seeing a patient for a while and you know that they have these fluctuations, and I look at this data here that says one of the values is showing that you're in the normal range. However, the impedance ratio is showing that you could still be in stage 1. We should consider being more conservative and using your sleeve ongoing. And this was important because the patient, every time she came into therapy, she was asking if she could discharge the sleeve. However, back in the first slide of this quick presentation here, I was sharing one of the reasons we do want improved quantification of lymphedema is for patient consistency, and to have them carry over the recommendations, have concrete information as to why they should still wear a sleeve or why they should continue to come to therapy for bandaging if needed. And this was the perfect example because the patient was reinforced, or our recommendation was reinforced with the patient when we were able to demonstrate that the impedance ratio is still a little bit high, and we just don't want to take a chance that she would have another exacerbation. And the patient was agreeable to that. And we continue to do ongoing surveillance with her. This is just another chart of her biometrics. You can see here, if we looked at just the traditional staging for lymphedema based on tape measurement, it would have suggested that she was in a healthy range, whereas the staging using the InBody bumped her up into the stage 1 range, which is more consistent with her presentation. She does present with persistent edema, lymphedema in her hand and her lower forearm. And so this is really important to acknowledge, because if you look at the overall tape measurement for her entire arm, she was coming out almost equally, because she had a larger bicep muscle on the left side, which was artificially increasing the overall tape measurement or limb volume for that affected arm compared to the unaffected arm. So it's really important to acknowledge it's convenient to do tape measurement. Many physicians are most comfortable with tape measurement. Insurances are comfortable with tape measurement. However, it's not the most sensitive type of technology. It's not a technology, right? It's not the most sensitive method of measurement for lymphedema, because it's not separating out extracellular water versus intracellular water, muscle mass, and fat mass. The second case study I want to take a few minutes to go through is a little simpler. It's a patient that I just saw in clinic as a return visit. I first met her in 2019. She's also a breast cancer patient. When we first met, her limb volume was essentially equal between sides. Her affected versus unaffected was only a 30 milliliter difference. I did discharge her. She was very active. We didn't do any reduction therapy for her, but I did discharge her with a flat knit compression class 2 garment because of her activity level, to help with active hyperemia and the increased demand on the lymphatic system when she was playing tennis. She did continue with her workout routine for 3 years on her own. She regularly wore her flat knit sleeve. She felt she had good containment with that. She only wore it for working out and air travel. Eventually, she decided to purchase her own over-the-counter sleeve and transitioned herself into that without my knowledge over those years. She reports that she felt stable in that, which is her own decision. She didn't have any concerns. Eventually, she discharged all of her compression during workouts, and she justified that because she switched from tennis to pickleball. She thought it was less aggressive for her arm. And so as a result, she stopped wearing compression altogether. In 2022, so just a month ago, the patient contacted me because she had been seeing a private massage therapist on the side who reportedly is trained in lymphatic massage. This therapist brought to her attention that she thought she suspected through palpation an increase in fluid volume in the upper arm portion of her affected arm. And so she requested to come back in for a formal evaluation. At this point, this is another patient who initially we only had tape measurement values for. She then returned 3 years later. Now we have the InBody. So we did we did take advantage of using the InBody 770 to get more specific quantification of what's going on in her arm, whether it's lymphedema or not. And so what we saw, we repeated the tape measurements, and they ended up being a lot less overall compared to her tape measurements in 2019. Possibly she lost weight. It's hard to say. That's the most likely reason. Both sides are equal. We added the bioimpedance analysis to the evaluation here, and you can see the extracellular water over total body water ratio came in at 0.381, which is healthy, so that was great. Her impedance ratio also came in on the healthy range, 1.0. However, what we noticed, was that the fat mass came in at 4.2 pounds. Now, we did not have an amount to compare this to from 2019. However, the 4.2 pounds for her right upper extremity is 200% of what the age norm would be for fat mass. So even though this woman was quite active, she did have a high percentage of fat mass in that arm. And so as we know, when we have patients question what they're truly palpating, especially in their upper arm region, saying that it's lymphedema makes us feel like it's less of our responsibility to have to worry about as patients, right? But at the same time, it's important to know if it is potentially fat mass, because that is obviously not the same kind of health risk as lymphedema would pose for the patient. And so we did discuss that is a likely reason for her to feel this increased, which what her therapist was describing as fluid volume, when really it was actually just some very likely fat mass. So that's another good example of how we use the full report, all of the biometrics, not just the fluid ratios and the impedance ratio and the phase angles, but also looking at the fat mass and muscle mass. For this patient, it was important to acknowledge that and let her feel comfortable that actually she probably is doing okay without wearing the garments, even though I did reinforce for someone who's at risk, she did have a full axillary lymph node dissection back when she had her initial surgery. And so she does remain at risk for lymphedema exacerbation. She should continue to wear her sleeve, especially with cardio like tennis or pickleball. There really would be no difference in terms of the increased fluid circulation or active hyperemia and that increased load to the lymphatic system. So we did review those recommendations, and she understands that even though she's stable with lymphedema, the ongoing recommendation is to still use the sleeve for exercise and air travel. So just to wrap up, clinical recommendations, we still use tape measurement because this is what insurance companies recognize. A lot of other institutions have access to water displacement values. That's perfectly fine too in perimetry. However, these specific means of measurement do not truly separate out what's lymphedema. So we do use those because that's what we have access to. A lot of the times that's what insurance recognizes. It can be more familiar to the physicians. There's more education that's required when you switch to a technology like bioimpedance analysis. However, that shift is critical. We have been working on that here at Shirley Ryan and through our primary referral sources, Northwestern Memorial Hospital through their breast cancer program. We've been working tirelessly over the last 2.5 years to train our team here as the therapy team, the physician team on the rehab side, and then educating not only the breast cancer medical team at Northwestern, but also at the other local hospitals here in Chicago where we get our referrals from. So it does take more effort and time on our part in the beginning. It's been, like I said, 2.5 years now of seeing. I've probably used the InBody on at least, I would say, 150 patients, maybe 200 in these 2.5 years, not just breast cancer patients, but also just all lymphedema patients, whether it's CVI or gynecological cancers for lower extremity, but the patients who have extremity-based lymphedema, so upper or lower extremities. And while it takes a little bit more time for me to explain in an evaluation or the assessment or the discharge summary, these are the tape measurements. However, this is what bioimpedance analysis shows us. I do feel like there's an improvement in the awareness of this technology in the field, and that is really critical. It does take some time and effort, but it is 100% worth it. The patients really appreciate having the printouts. They like the feedback. They like having that reinforcement. It justifies for insurance why I see someone for 6 months who's stage 0, because I might still see them once a month for surveillance for 6 months. And that's really important because a lot of cases, there are enough cases that I catch in those first 6 months after the patient has the effects of radiation, let's say, and they have an increase in lymphedema suddenly that we would have never caught if we didn't keep this patient on for surveillance. And so that's really important to acknowledge too. This technology is really critical for that. So thank you for this opportunity to speak with you today. I apologize that I can't be with you live, but I hope that this recording was helpful to provide a clinical perspective of the daily life of a therapist using the InBody. So thank you very much.